Thank you for inviting me to speak today on the topic of neonatal hyperbilirubinemia and cholestasis. My name is Kelsey Donoho. I'm a neonatologist and assistant professor of pediatrics at the George Washington University in Washington, D.C. For today's talk, I will be focusing on an aspect of cholestasis that we encounter regularly in our neonatal intensive care unit at Children's National, which is parenteral nutrition-associated cholestasis. I have no conflicts of interest or financial disclosures for this talk. During today's talk, we will cover 4 objectives. First, we'll review the criteria for diagnosis of parenteral nutrition-associated cholestasis, as well as the pathophysiology and risk factors for its development. I'll then outline strategies to help prevent the development of parenteral nutrition-associated cholestasis in the neonate. I'll discuss management options for those patients who do develop cholestasis. And finally, we'll review long-term outcomes data and treatment options for patients with parenteral nutrition-associated cholestasis and intestinal failure-associated liver disease. For infants in the neonatal intensive care unit with short bowel syndrome and intestinal failure, total parenteral nutrition is required to prevent dehydration and malnutrition, while enteral nutrition is not feasible. Unfortunately, these patients are at high risk for development of parenteral nutrition-associated cholestasis, or its newer term, intestinal failure-associated liver disease. For the purposes of this talk, I'll use the term parenteral nutrition-associated cholestasis. Patients receiving parenteral nutrition should undergo regular laboratory monitoring while on parenteral nutrition to evaluate for the development of cholestasis and liver disease. Markers include serum conjugated bilirubin, alkaline phosphatase, serum aminotransferases, and gamma-glutamyl transpeptidase. A persistent concentration of conjugated bilirubin greater than 2 mg per deciliter for patients who have been on parenteral nutrition longer than 2 weeks meets the criteria for parenteral nutrition-associated cholestasis, so long as no other cause is identified. Standard evaluation for other causes of cholestasis include an abdominal ultrasound to evaluate the hepatobiliary system, serological tests for viral hepatitis and cytomegalovirus, metabolic screening for hypothyroidism and galactosemia, and screening for urinary tract infection. When parenteral nutrition cannot be discontinued, patients with intestinal failure are at risk for gradual progression of liver disease from portal fibrosis and splenomegaly to cirrhosis and eventually to end-stage liver disease. Intestinal failure-associated liver disease represents the most consistent negative prognostic indicator for overall survival and is the leading indicator for transplant in short bowel syndrome patients. While the name would suggest otherwise, the pathophysiology of parenteral nutrition-associated cholestasis is multifactorial. While some infants have a propensity for cholestasis, whether due to a potential genetic predisposition or other factors like prematurity, there are a number of other contributing components, some of which are modifiable. A unifying interaction called the gut-lipid-liver axis has been proposed to describe the synergistic mechanisms contributing to parenteral nutrition-associated cholestasis. The foundation here is the initial cause of intestinal failure, whether due to infection, malformation, or ischemia. Short bowel syndrome patients are at risk for an altered intestinal microbiome and small bowel bacterial overgrowth. This predisposes them to small intestine inflammation, which can impair the intestinal barrier function, leading to abnormal absorption of molecules such as endotoxin across the small bowel mucosa that promotes hepatic macrophage activation and generates other inflammatory mediators. Particular intestinal bacteria are also associated with liver injury, notably Bacteroides and Proteobacteria. Patients with small bowel syndrome are also at risk for sepsis and bacteremia secondary to their dependence on central venous catheters. This also results in the systemic release of pro-inflammatory cytokines. Regardless of whether the source of infection and inflammation is from a primary gut source or from a central line-associated bloodstream infection, the end result is decreased hepatocyte bile acid transport, which results in increased bile acid concentration and toxicity to hepatocytes. The third component of the gut-lipid-liver axis references the role of intravenous lipid emulsions in parenteral nutrition, which we'll discuss in greater detail later on. Risk factors for the development of parenteral nutrition-associated cholestasis in neonatal patients can be divided into nutrient-dependent and non-nutrient-dependent risk factors. Nutrient-dependent risk factors include degree of nutritional support required from parenteral nutrition compared to enteral nutrition, caloric content and glucose infusion rate, as well as the type and amount of lipid emulsion used. Exposure to excess lipid calories from higher doses of IV lipid emulsions is associated with development of cholestasis. There are multiple mechanisms postulated related to inflammatory cytokines, accumulation of phytosterols, and direct effect of lipid on hepatocytes. Non-nutrient dependent risk factors carry greater relative weight for development of cholestasis, but unfortunately few of these are modifiable risks. Risk for cholestasis is closely related to degree of prematurity and lower birth weight, particularly in growth-restricted babies. The immature liver of the preterm infant plays a role in development of cholestasis. Preterm infants have a reduced total bile salt pool, as well as diminished hepatic uptake and synthesis of bile salts and reduced enterohepatic circulation. The preterm liver may also be more susceptible to toxic damage due to a deficient process of solubilization of toxic bile salts. Growth restriction also confers a greater risk for persistent cholestasis, likely due to altered hepatic fatty acid metabolism. Younger age at initiation of parenteral nutrition, delayed start to enteral feeding, and longer duration of parenteral nutrition all increase the risk for development of cholestasis. Neonates with necrotizing enterocolitis as their underlying cause of short bowel syndrome are at even greater risk compared to neonates with other operative conditions such as intestinal atresia or gastroschisis. Sepsis is another risk factor associated with its development. It should be noted that intestinal failure can be functional or anatomic. Patients who are intraoperative with an enterostomy, patients with strictures, adhesions, small bowel dilation, and secondary stasis can all have poor motility and small intestine bacterial overgrowth, even with adequate bowel length. As our intestinal rehabilitation program likes to say, the bowel is short when it acts short. Now that we've discussed the definition and risk factors for parenteral nutrition-associated cholestasis, I'll outline strategies to prevent development of cholestasis in high-risk neonates. Strategies should address both parenteral and enteral sources of nutrition. Prevention of sepsis and CLABSI are important safety and quality practices for any ICU, but is of particular importance for intestinal failure patients given their multiple risks from small intestine bacterial overgrowth and long-term central line requirement. Excellent central line care is critical both to ensure the ability to adequately deliver parenteral nutrition without interruption, as well as to avoid infection, which is a known risk factor for development and worsening of cholestasis. Small bowel bacterial overgrowth is a serious concern in short bowel syndrome patients, and there is evolving role for pre or probiotics as well as cyclic antibiotic treatment. These therapies should be given careful consideration in the neonatal population and is not standard practice in our NICU. Most important is the focus on delivery of intraluminal nutrition. Intraluminal nutrition in any amount is critical to avoid mucosal atrophy of the intestinal tract. Nutrition could be breast milk or amino acid-based formula and can be delivered orally or via enteral tube. For long-term management of short bowel syndrome, continuous enteral feeds are preferred due to constant mucosal stimulation and better nutrient absorption and higher rate of long-term achievement of intestinal autonomy. An understanding of the role that IV lipid emulsions play in the development of parenteral nutrition-associated cholestasis is also important, which we'll discuss in greater detail later in the talk. Support for intraluminal nutrition delivery requires the clinician to be proactive from day one. Early enteral feeding should be attempted whenever possible in patients at risk for parenteral nutrition-associated cholestasis. Early feeding is relevant both in the initial days of life as well as when considering reinitiation of feeds after diagnosis with necrotizing enterocolitis or after other periods of fasting. A 2014 retrospective study done at Children's Hospital of Michigan demonstrated that earlier enteral feeding had the greatest potential to reduce the development of TPN-associated cholestasis amongst a number of other potential modifiers. In those patients who do require long-term parenteral nutrition, the question of how to provide optimal nutritional delivery with minimal harm is ongoing. Lipid emulsions containing omega-3 and 6 polyunsaturated fatty acids are a critical component of parenteral nutrition to prevent essential fatty acid deficiency. Fatty acids play several critical roles in cellular pathway and signaling, gene expression, cell membrane structure, and transcription factor activity. Soybean oil was first introduced into clinical practice in the 1970s in the United States and was the predominant lipid emulsion used in parenteral nutrition for decades. Mixed oil lipid emulsion has gone through various generations of development in parenteral nutrition, but it is a general term referring to any emulsion that is not a single source lipid, and there are several generations of mixed oil lipid emulsions. For this talk, when I refer to mixed oil lipid emulsion, I am referring to a fourth generation, 4-source multi-component lipid emulsion that includes medium chain triglycerides, as well as soybean, olive, and fish oil. This lipid emulsion type was commonly in use in Europe since the mid-2000s, before it was approved for use in adults in the United States as of 2016, and has been used off-label in pediatric patients. The coconut oil component supplies medium-chain triglycerides, which do not accumulate in the liver, are easily metabolized, and have an anti-inflammatory profile. However, medium-chain triglycerides are not suitable as the sole lipid source and must be combined with oils that contain essential fatty acids in order to prevent essential fatty acid deficiency. Fish oil lipid emulsion has been approved for use in pediatric patients with parenteral nutrition-associated cholestasis in the United States as of 2018. Exposure to pro-inflammatory components from lipid emulsions may be a contributing factor in the development of fatty acid-induced liver injury. Soybean and other plant-based intravenous lipid emulsions are known to contribute high concentrations of pro-inflammatory omega-6 polyunsaturated fatty acids, with a ratio of linoleic acid to alpha-linoleic acid of 7:1. This effect is demonstrated particularly at higher doses greater than 1 gram per kilo per day, which have been associated with development of cholestasis. Some studies have demonstrated resolution of cholestasis after the dose of soybean lipid oil emulsion is reduced to 1 gram per kilo per day. However, the evidence is conflicting, and there are potential adverse effects to the chronic dose reduction, including the potential for essential fatty acid deficiency and possible negative impacts on brain growth and development, particularly due to its lack of desirable very long-chain fatty acids, DHA, ARA, and EPA. Because it is plant-derived, it is naturally high in phytosterols that have a tendency to accumulate in hepatocytes and lead to reduction in bile acid synthesis and bile flow at higher doses. Soybean oil lipid emulsion use has also been associated with higher incidence of BPD events. This has been postulated to be the result of the higher concentrations of linoleic acid, prostaglandin E2, leukotriene B4, and thromboxane A2, all of which can lead to pulmonary vasoconstriction and a pleuroinflammatory state. Fish oil lipid emulsion has an anti-inflammatory profile due to its rich source of omega-3 polyunsaturated fatty acids with high concentration of DHA and EPA. It is also supplemented with vitamin E in the form of alpha-tocopherol. Since it contains no plant oils, there is minimal concentration of phytosterols. In the United States, mixed oil lipid emulsion has off-label approval for use in infants and is used as our standard IV lipid emulsion at Children's National in the neonatal intensive care unit, allowing us to provide an optimal delivery of calories from sources other than carbohydrate while minimizing the pro-inflammatory and hepatotoxic effects of soybean oil. It has an omega-6 to omega-3 fatty acid ratio of 2.5:1 with lower phytosterol and higher vitamin E concentration compared to soybean oil lipid emulsion. One notable consideration for use of mixed oil lipid emulsion is its limited compatibility data, which can impact central line management. It should be mentioned, however, that a 2019 Cochrane review found insufficient data from randomized studies to determine potential benefit of any lipid emulsion, including fish oil, over another lipid emulsion for prevention of parenteral nutrition-associated liver disease. The management strategy once parenteral nutrition-associated cholestasis has developed is multifaceted and targets infection prevention, nutrition, intestinal health, and promotion of enteral autonomy and pharmacologic therapies. To reemphasize, central line care remains foundational in the ongoing management of parenteral nutrition-associated cholestasis. Delivery of intravenous lipid emulsions increases risk of central line-associated bloodstream infection related to its optimal pH for microbe growth. Whether any particular lipid emulsion is associated with higher risk of CLABSI is controversial. Regardless, infection and sepsis is associated with increases in conjugated bilirubin and often impairs the progression towards enteral autonomy. An ongoing commitment to increasing intraluminal nutrition delivery is critical, while in the meantime tailoring TPN content for the needs of the cholestatic patient. In our unit, we make directed changes to our parenteral nutrition aimed at cholestasis management after the conjugated bilirubin level exceeds 2 milligrams per deciliter. Long-term parenteral nutrition for short bowel syndrome has the potential to develop toxicity of some components, whereas other components should be delivered at increased doses to avoid deficiency. Cholestatic patients are at increased risk for manganese accumulation and toxicity due to its mode of excretion via the biliary tract. Consequently, we remove trace elements containing manganese from our TPN in cholestatic patients. Copper is another trace element that requires modification due to its mode of excretion via the biliary tract. while preterm infants typically have high copper requirements to achieve in utero accretion rates and patients with GI losses have additional potential for copper deficiency, we typically need to lower the amount in TPN in the setting of cholestasis, generally to 20 micrograms per kilogram per day, while monitoring for copper deficiency. We also increase zinc delivery, which is particularly helpful in patients with gastrointestinal losses. Adjustment to the lipid emulsion type and dosage is an additional critical intervention in the management of cholestasis. There is an ongoing quantity versus quality debate regarding the management of IB lipid emulsions in parenteral nutrition-associated cholestasis, particularly as it relates to the neonate. Several randomized open-label trials now indicate that a reduction in soybean oil IV lipid emulsion to 1 gram per kilo per day can effectively reverse parenteral nutrition-associated cholestasis. In patients maintained on minimal lipids, it is important to ensure adequate caloric delivery, which usually can be achieved via increasing the glucose infusion rate if blood glucose values allow. It is also critical to monitor for development of essential fatty acid deficiency, which literature suggests can occur in a substantial portion of infants treated with low-dose soybean oil lipid emulsions. Alternating soybean oil lipid emulsion and mixed oil lipid emulsion helps avoid or can be used as treatment for essential fatty acid deficiency in the cholestatic patient. Our practice is generally to do 4 days a week mixed oil and 3 days a week soybean oil. We maintain our lipid infusions at the minimum dose if we are able to meet caloric needs, avoid essential fatty acid deficiency, and achieve appropriate growth. Fish oil lipid emulsion has been approved by the FDA for use in treatments in infants as a treatment to reverse intestinal failure-related cholestasis in infants and children. However, prolonged use of fish oil lipid emulsion carries a theoretical bleeding risk due to its impact on platelet aggregation, and thus is contraindicated in patients with hemorrhagic disorders. This risk is not borne out by the medical literature, as studies have demonstrated higher bleeding incidence in patients receiving soybean oil lipid emulsion compared to fish oil. Patients are also at risk for development of essential fatty acid deficiency and require continued monitoring when receiving fish oil lipid emulsion. At our institution, we switch back to our standard lipid emulsion when the patient is tolerating 50% of feeds and otherwise require a demonstration of improvement in cholestasis to continue therapy. Ursodeoxycholic acid is a pharmaceutical option for treatment of parenteral nutrition-associated cholestasis. A natural component of bile acids, it is absorbed mainly in the distal ileum, where it competes with endogenous bile acids for active transport and to supply the intrahepatic circulation. It functions mainly to improve bile flow and reduce formation of biliary sludge. Unfortunately, evidence has been mixed regarding its efficacy. A 2023 meta-analysis, including over 2,000 infants and children with cholestasis, did not associate its use with improvement of clinical symptoms, or it did associate its use with improvement of clinical symptoms and biochemical markers of cholestasis. However, evidence in the neonatal population has not consistently demonstrated significant benefit regardless of dose. Of great concern is that higher doses in the neonatal population has been associated with adverse effects, specifically progression of liver failure and death. At this point, there are no clear guidelines for timing of initiation and duration of treatment. In general, it should be considered within 2 weeks of cessation of TPN if there is persistent cholestasis. The use of oral erythromycin as a prokinetic therapy is common in patients with impaired gastrointestinal motility. Its mechanism is twofold, working both to promote GI motility by stimulating motilin receptors in the GI tract, as well as impacting the intestinal microbiome. And literature review supports its use in neonates, including premature infants with functional GI motility, to facilitate rapid advancement of feedings and weaning off of parenteral nutrition. Finally, I want to highlight that there is room for optimism for long-term outcomes of patients with parenteral nutrition-associated cholestasis. We can be reassured that for those patients who are able to achieve intestinal autonomy and discontinue parenteral nutrition during their NICU stay, biochemical outcomes for cholestasis are reassuring, particularly if weaning can be achieved within 90 days. Majority of patients will demonstrate decline in conjugated bilirubin levels following cessation of parenteral nutrition. It's important to note, however, that the data shows us that a subset of patients will demonstrate a continued rise in conjugated bilirubin levels for several weeks, even after cessation of parenteral nutrition, particularly patients treated with ursodeoxycholic acid. Fortunately, the natural history after cessation of parenteral nutrition, even for this subgroup, is eventual biochemical resolution of cholestasis. However, most studies do not address severity of hepatic fibrosis in long-term outcomes measures. At the beginning of the talk, we touched on the potential consequences of intestinal failure-associated liver disease, which can lead to portal fibrosis, cirrhosis, and eventual end-stage liver disease. For patients with short bowel syndrome, long-term treatment options include continued parenteral nutrition, intestinal rehabilitation and adaptation, and combined liver and small bowel transplantation. It's critical to have an experienced intestinal rehabilitation program to transition management of short bowel syndrome patients after their initial NICU hospitalization. The intestinal rehabilitation program at Children's National, led by Dr. Claravet Torres, has excellent success achieving enteral autonomy in patients with short bowel syndrome, with a median of 5 months to achieve enteral autonomy. Their program's 12-year outcomes data from 2007 to 2018 is remarkable for their 97% transplant-free survival rate and 99% resolution of cholestasis with medical therapy. It's important to emphasize that while intestinal adaptation is most rapid during the first year of parenteral support, achievement of enteral autonomy is still possible even after years of resilience on parenteral nutrition. This concludes my talk today. Thank you so much for your attention.